And we're back at Nurse Practitioner Television. This is attorney and nurse practitioner Joe Flores. This is powered by South Texas Crossfire and Lopez Broadcasting. And I want to talk about something very serious, and that is the opioid crisis. Many of us have heard of the show The Pharmacist on Netflix. We've seen the devastation of the opioid crisis on the front lines out in the United States. And we've also read in the media about the bankruptcy of Purdue Pharmacy and that bankruptcy being lifted, and many holding Purdue Pharmaceuticals responsible for being the catalyst for a lot of this addiction. With us today is a physician on the front lines talking about the opioid crisis, and here is his take. Doctor, we're back after a brief break. Thank you for joining us again. I know you're busy, but there is a topic that you wanted to address the community on, not just here in South Texas, but it has national and international ramifications. And tell us about that.
Okay, well, it's a condition called herpes encephalitis. And people, when they hear the word herpes, they think of genital herpes, but that's not what I'm talking about at all. The chickenpox virus is a herpes virus. So is the virus that causes infectious mononucleosis. So the chickenpox virus, when you get it, it never leaves the body. It lives in the dorsal root ganglia. Those are the nerve root bulbs that come out at the level of each vertebrae. So the classical presentation, when it becomes reactivated, which could be during a time of stress when you have an increase in cortisol level, which weakens the immune system, but just it can be random as well. The classic presentation is shingles. So it comes back, it causes a painful rash in the distribution of only one nerve. That's why shingles rarely crosses the midline. But at the dorsal root ganglia, there are no guards there saying, oh no, herpes virus, you can't go into the spinal cord and into the brain tissue. And sometimes it does. And I've had hundreds of cases of it. So what happens is when it goes into the spinal cord, into the brain tissue, it causes weird neurological symptoms. Like, for example, I've had patients that say things like, well, I had a tremor in my hand, and then my other hand, and then my right foot, and then we check the antibody levels, and to my astonishment, often not only is the IgG elevated, but the IgM is elevated. So those are types of antibodies. They're called immunoglobulins. So when you first get infected with something that you're naive to, you'll get an elevation in your IgM level. That's the acute phase immunoglobulin or antibody. And then after a while, after maybe a week, the IgG, which gives you permanent immunity, supposedly anyway. The IgG level goes up and the IgM level goes down. And it's having an IgG level that's elevated gives you immunity for whatever reason. And I'm not sure why. I'm finding a lot of people that test positive for these antibodies to be elevated have both an IgM and an IgG level that are elevated. So they have these weird neurological symptoms. Often they've been to the ER, they've had CAT scans, they've seen specialists. I've had one patient that was admitted for like 45 days in San Antonio. She passed out and woke up in the ICU. And these patients progressively worsen. So if left untreated, it can cause scarring in the brain tissue and the spinal column, which is what multiple sclerosis is. But if you look up multiple sclerosis, it'll say unknown cause. But every case that I've ever encountered, I've checked the antibody levels and they've been elevated. The herpes zoster, which is the varicella zoster, which is the chickenpox virus.
This is, and a lot of this for our laymen that are non-medical personnel, we've broken it down a little bit better where we have the nerve roots that are coming out of the back in layman's terms, and there's the antibodies that are supposed to show a flipping where there's some sort of antibody, but you mentioned that they're both mixed. So what does that mean? That it never gets resolved, or no antibodies
It
are
means
formed?
that they lost their immunity to the chickenpox virus somehow,
okay.
and that they got reinfected, but it became reactivated. But instead of going out on the skin and causing shingles, it goes into the brain and causes weird neurological symptoms.
And the average person, I mean, the average physician, diagnostician is not going to catch that unless they've seen hundreds of these cases like you have.
Well, doctors aren't looking for it. That's the problem. And the treatment is very simple. So in the mid 80s, a medication called acyclovir was invented to combat the herpes, genital herpes outbreak. And so it's an old medication. Some people that have severe cold sores or genital herpes have been taking acyclovir every day since the 1980s. So the treatment is, the way I treat it is I give patients acyclovir 4 times a day and do that for 2 weeks and have them come back, and then reduce it to 3 times a day for 2 weeks, and then twice daily for 2 weeks, and then once daily, sometimes for a month or sometimes for 2 weeks, depending on the severity of the symptoms. I've never had a patient that didn't get better. I've had patients come to me in wheelchairs that had been seen by numerous specialists. Nobody bothered to check a varicella zoster antibody level. I check it, I put them on therapy. I have had patients that come to me in wheelchairs. 2 weeks later, they're using a walker. 2 weeks later, they're using a cane. 2 weeks later, they're back to work. And these are healthy, otherwise healthy young people with families.
And, of course, you're licensed here in Texas, but as a general principle, medical principle, nurse practitioners that are watching this on MPTV, to keep in mind what? When they come in and see somebody that is what, in their 6th, 7th decade or even younger?
No, there's a lot of the patients are young, healthy patients. So just like you see shingles in random age groups, you see herpes encephalitis in random age groups as well. Basically, this is the bottom line. If a patient comes in with weird neurological symptoms and the CAT scan's negative, maybe an MRI is done and it's negative, check a varicella zoster antibody level. It's a simple thing to check. And if it comes back elevated, we've got nothing to lose by putting them on acyclovir. I add a little gabapentin, which is good for nerve irritation, thiamine, which is good for nerve irritation, and also folic acid. Now, I've never had a case where the patient didn't get better or get the symptoms completely resolved. And it's something that nobody seems to be looking for. And if you look in the medical literature, there's not very much information on it. But it's a big problem, and I'm trying to raise public awareness about it because, the consequences of this being untreated is devastating.
But for a simple test, what happens if they go undetected? Are they going to neurologists, therapists, unnecessary treatment, expense? What happens?
Well, forget the expense. This is devastating to people because what happens, it can lead to multiple sclerosis or scarring in the brain and the spinal cord, in the tissue. And that's permanent. Once it gets to that point, the change is irreversible. No, you can't reverse the scar tissue with acyclovir. So these people, and a lot of them are young people, like in the mid-30s, 40s, and you can imagine how devastating it is to the families. A lot of these people that I've treated have had young children. It also, people like an elderly person, for example, that is maybe in their 70s, they start to develop signs of dementia. Well, sometimes it's not dementia, it's herpes encephalitis. So in those cases, often, like if the family comes in and says, yeah, well, he's got dementia, and it's like, okay, no, it's not okay. If I check that varicella zoster antibody level, it's elevated, I treat them, they get better.
This is unbelievable. Yeah, I'm glad you brought this up to the public, and for the people out there. Again, I want to emphasize this is not a sexually transmitted deal. It could be from chickenpox.
It is the chickenpox virus, varicella zoster.
Okay. Well, thank you, doctor, for that. Any final words on this topic?
Just check the antibody level if you have a patient with weird neurological problems that don't make sense.
For the nurse practitioner and for the layman, go see the physician of your choice and ask more about this information.
Yes.
Thank you. Thank you very much.
What else you got?
The opioid crisis.
Okay.
And then however long you want to go on there, but I'm probably just going to do a quick intro in there. No big build up because I'm going to be adding stuff on there. Okay. Doctor, a lot of people have been watching The Pharmacist on Netflix.
I've watched some episodes.
And also Purdue Pharmacy coming out of bankruptcy, and since 2007 they pled guilty to mislabeling and kind of misleading physicians. I just wanted to get your take as a doctor that's been around and also has dealt with people in pain. What is your take on what's going on with the opioid crisis?
Well, it is a crisis. And I think that a lot of times these pharmaceutical companies, they know what they're doing. They know exactly what's happening. They know the addictive properties of their medications, and they're getting rich off of it. I mean, just because they're a pharmaceutical company doesn't mean they have integrity. I mean, a lot of these people that own these pharmaceutical companies, these corporations, they're publicly traded corporations, and they'll deliberately affect the drug market in order to make a bigger profit. There was a pharmaceutical company called Valiant that actually was found that they were buying small pharmaceutical companies that had a monopoly on a drug, that they were the only company that was making it. They bought hundreds of these companies, and people whose lives depended on it were the only ones that were taking the drug. Like, for example, there was a case of patients, a medication for Wilson's disease, which is a problem with metabolizing copper. And so the patients went from having a $10 a month copay to $22,000 a month copay. So these pharmaceutical companies, just because you would expect them to behave with integrity, and some do, I'm sure a lot of them do. Please don't misunderstand me, but there's a lot of corruption. I mean, they see their duty is to make as much money as they can for their shareholders, and they more so than being concerned about the public welfare. So I have no doubt that pharmaceutical companies that produce opioids and sell opioids, they know exactly what they're doing.
In the case of Purdue Pharmacy, what is your understanding of their culpability for causing or being the catalyst for this opioid crisis?
Well, it's not just them. Okay, it's not just them. I would say that in their defense, but I mean, I've watched the story, The Pharmacist on Netflix, and the story reeks of corruption. I don't think that. I mean, they wouldn't plead guilty unless they were guilty, unless there was overwhelming evidence. Now, the opioid crisis is a dilemma, an ethical dilemma for physicians. We have patients that truly have pain. Like, you can do X-rays and see, people that have like joint space is almost completely gone, for example, between some of the vertebrae in the lower back, or people that have like one leg shorter than the other and they have orthopedic hardware. I mean, obviously these people are in pain. Some people tolerate the pain well with just medications like ibuprofen, and others don't. And so this whole situation, which in part was caused by physicians, we have to assume our responsibility for the problem as well. Not just physicians, but pharmacies and pharmaceutical companies, and part of the blame is on some of the patients as well. But some people just have a propensity for addiction to one drug or the other. Like, for example, there are people that can use cocaine 2 or 3 times and they're addicted. And there are people that can use it 2 or 3 times a month and then walk away from it completely and never get addicted. And I don't know why that is. It's not my area of expertise, but I'm sure it has to do a lot with the chemical receptors in the brain. But regardless, as far as the opioid crisis, it's a real crisis. A lot of people are dying over it, overdoses, and now that doctors are being scrutinized to the degree that, like me, I hardly prescribe any pain medications anymore because I don't want the scrutiny, or any controlled substances for that matter. So there are patients that have turned to street drugs like heroin, and there have been reported cases of people that dying of heroin overdoses that used to be on, that have real orthopedic problems, that used to be on prescription pain medications, but nobody will give them their prescription pain medications anymore.
So when we see that, there's the argument that somebody like Purdue Pharmaceuticals put out something. They told physicians this is a panacea for pain. It's going to cure, and it's not really addictive. And now everybody, as you said, prescribers are under scrutiny, so they're not going to give it. So we've cut off these patients after a decade or more. Do you think that they should be held responsible as the people that misled physicians and the Food and Drug Administration?
You know, everybody involved is to blame to some degree. We all are. Physicians, nurse practitioners, pharmacists, pharmaceutical companies, patients, everybody is to blame to some degree. The situation got way out of control and remains out of control. But it's not the first time this has happened. Like Hong Kong used to be the capital of opium, the opium business for the British. That's why Great Britain controlled Hong Kong forever. Only until recently they returned it back to China. But that was the port that they used to import opium, and a huge percentage of the Chinese population back in the 1800s was hooked on opium, mostly as a result of the overwhelming quantity of the supply.
And when it suited the British, they said this is bad. So it was more like a moral sort of imperative, and then they stopped the profit, but not after a century of making it.
Right, exactly. And so it's unfortunately, one thing that is probably always going to be a problem with human beings is the addiction problem.
One thing that, very briefly in the couple of minutes we have left, veterans that were coming back from Iraq, Afghanistan, they were given pain medication. And to this day in the VA, some nurse practitioners and physicians, if they don't alleviate pain, they'll get in trouble. So it's almost like it's still going on. The pain, delivery, relieving of pain with medicines, with opioids. So, I mean, what is an alternative to Percocet, to Lortab that is coming out? I mean, there is an alternative, isn't there?
Well, I'm not sure the alternatives are any better than the Percocet and the Lortab.
Like Suboxone?
Like Suboxone. It's equally as addictive. You just don't get the euphoria. But the problem is it's always going to be there. Now, back in the 80s, you could get written up by the medical board for not treating somebody's pain. Well, we know all that's changed. And so it's something that, has always been a problem, I think, as long as there have been addictive substances, which has been for many, many years.
Many people have told me when they go fill their prescriptions, they now encounter barriers where they didn't after 2014. Now they're encountering barriers. These people are in legitimate pain. They tell me I'm being treated like a criminal when I go in there. I'm suspect. My family doctor can't give me anything. I have to go to a pain specialist. What do you tell those people? That come in and say, doctor, you're my internal medicine, you're my family doctor, I need my opioids and I can't get in to see a pain relief guy for 3 months.
Well, I have some great working relationships with some pain management specialists, and usually if a patient is in dire need like that, I can get them in within a day or two. Also, I'm not opposed to giving like some Tylenol number 3s or something like that for a short period of time until they can get in to see the pain management specialist. So like if somebody comes in and, for example, that's from out of state and they're almost out of pain medications, they have horrible pathology, proof of medical necessity, I'll text one of my pain management buddies and say, hey man, this is the situation, this is the patient's name, date of birth, and phone number. They just moved here, whatever the circumstances are. Maybe also send over a picture of their x-rays, showing where the pathology is. And so I don't really have problems with that as far as like directing people, getting them in to see pain management right away. But if they try to pressure me to prescribe them something and I'm not convinced that they really need it, I'll just say no. And no one's going to pressure me enough to cause me to take out my pen and write them a prescription for something that I don't feel comfortable doing. So I'll ask them to leave, and if that was a situation. But other times there's been people that don't want to go to pain management, that want me to take care of their pain medications because as their primary care physician. And I just explain to them, and I do sometimes, a very, very, very small amount, but I've explained to them that, look, I'm sorry, the system is not perfect, but this is the way it is. And I know you're not asking me to jeopardize my medical license, but I can't put myself at risk like that. And so even if they're a little reluctant, me being able to get them in to see pain management very quickly, I'm able to deal with the situation pretty well.
And for our nurse practitioner audience, for those people out there, over 100,000 nurse practitioners that are reached by this interview, what would you tell them about handling pain management? They come in a backcountry clinic. They go into an urban area that's underserved. What kind of advice or input would you give them?
Don't do it. Don't do it. Don't work for a clinic. I would tell every nurse practitioner watching, don't work for a clinic where they hand out pain medication or controlled substances very liberally, because you're just putting yourself at risk. All the years that all of us went to school, all that training, all that effort, all having to make the high test scores, all of that effort, don't jeopardize it over this. Stay away from it, stay as far away from it as you can.
And the patients that legitimately need pain, there's a compassionate way to do it. Punt to a pain management guy.
Exactly. And if they can't get in for 3 months, okay, then give them a minimal amount of narcotics when you have proof of medical necessity and you followed all the guidelines. One problem with the guidelines, though, is that, for example, the Texas Medical Code says physicians should consider urine drug screen. Physicians should consider checking the pharmacy monitoring program. Physicians should consider a contract with the patient, a narcotics contract. But that's not what they really mean. What they really mean is you must do these things. So as the nurse practitioners that are watching, I would urge them to make sure you're doing urine drug screens, make sure you have the narcotics contract, make sure that you have sent them to physical therapy, tried alternative methods of treating the pain. And urine drug screens are a must. And also, if you have to write for pain medication, just have a limit. Like, for example, what I do is when I write for pain medication, I'll write the maximum I'll give is 60. Even if they have horrible pathology, and that's the only way they'll get it, by the way. You have to have proof of medical necessity. But as long as you're doing that, you're following all those guidelines, and the patient maybe, if you're in a rural setting where there's not a pain management specialist, that maybe for 100 miles and the patient doesn't even have a car or something like that. As long as all those guidelines are followed, you could write for 60 Tylenol number 3s a month, and then recheck a drug screen every 3 months at least. And if you do that, you're safe. Because the people that are looking for something stronger than that, or looking to abuse prescription medications, you're not going to be the one they want to see.
Right, that's correct. Well, thank you for your time.
You're welcome. Thank you.
I know how busy you are, but we really appreciate your input.
Well, thank you very much, Joe.
Thank
Appreciate
you.
it. Thank you.
That's all we have for today. Thank all the nurse practitioners and all the important work they do. All healthcare providers throughout the United States. We're facing a lot of crisis. We're facing the opioid crisis, the diabetic crisis. And we want to thank Dr. Mario Martinez for being on as our special guest. And I want to reach out to all the nurse practitioners. Join us on Nurse Practitioner Television on Facebook, and also like us, follow us, and also on Instagram. And thank you so much, and God bless.